Good evening, everyone, and a warm welcome to this webinar. We are MedGenome, leaders in genetic testing in India. And today's webinar is brought to you in association with Key Hospital and Research Foundation, Kolhapur. And the topic for today's webinar is IUI, when, how, and when not. And we have two speakers for the evening. Starting off with Dr. Priyashi Pandi, who is the head of scientific affairs at MedGenome. Dr. Priyashi obtained a master's from Maharaja Shaji Rao University, Department of Microbiology and Biotechnology. She completed a postdoctoral degree from Utah State University, USA. She has over 10 years of R&D experience in pharmaceutical, biotechnology, and molecular diagnostics sector in USA, UK, and India. He has worked with a number of pharmaceutical, stem cell research, molecular biology, and medical genetics firms. And she has won fellowships and published multiple papers in this field, particularly in cell and molecular biology. She has also worked with multiple big companies such as Sun Pharma, GE Healthcare, Roche Diagnostics, Genes2Me, etc. And she has been working in the field of genetic diagnostics and oncology and prenatal diagnosis for the past 8 years. And she is, as I mentioned, she's the head of scientific affairs at MedGenome. Our second speaker tonight is Dr. Shweta Patki-Kulkarni. She's a consultant gynecologist at Patki Hospital, Kolhapur. Dr. Shweta completed her MBBS from BJ Medical College, Pune, MS in obstetrics and gynecology from FY Patil Hospital, Kolhapur. She is a trained clinical embryologist from the Cleveland Clinic in the USA. And she's won fellowships in infertility and endoscopy. She did a postgraduate diploma in hospital and healthcare management and is currently working with Key Hospital Kolhapur since 2016. She specializes in infertility and high-risk pregnancy management. So before I hand over to the Dr. Priyashi, I'd like to inform the audience that if you have any questions or comments, please use the Q&A window of the Zoom interface, and we will address your questions at the end of the session. So without any further delay, I will now stop sharing and hand over to Dr. Priyashi Pandi, and I request her to keep this forward. Over to you, Dr.
So thank you for the introduction. So very good evening to everyone for taking out their precious time and joining this webinar. I thank Dr. Shweta and the management of Patki Hospitals for giving us this opportunity. So today the title of my talk will be Recurrent Pregnancy Loss, and also I will discuss briefly the genetic causes of male infertility. So basically, what is recurrent pregnancy loss? So recurrent pregnancy loss is nothing but 2 or more miscarriages either happening consecutively or non-consecutively. And this is actually more common than thought. So it occurs in almost 5% of the women, and both maternal and fetal causes are involved in recurrent pregnancy loss. So this pie chart over here kind of elucidates the common causes of recurrent pregnancy loss, and as you can see that almost in about 40 to 50% of the cases, the causes are unexplained or are not known. 2 to 5% of these pregnancies basically constitute of genetic abnormalities due to which there is recurrent pregnancy loss. And this presentation will basically focus on what are the types of genetic abnormalities which can lead to cause recurrent pregnancy loss. So the first in this category of genetic causes of RPL is basically chromosomal abnormalities, or in other words, translocations. They are the most common cause of first trimester losses, and they account for almost 30 to 40% of all genetic causes and roughly about 2 to 3% of our RPL cases. So they constitute the largest number of genetic abnormalities responsible for RPL cases. Other than this, we can have other lethal genetic conditions which can be single gene related. These are quite rare, but these genetic conditions might be involved in embryonic development as well as other fetal developmental genes. If there are recessive mutations or even dominant mutations in any of these genes, then this could also be cause of recurrent pregnancy loss. And then the third case is, this is basically responsible for primary infertility, but basically some of the genetic causes that lead to male infertility, which will actually cause primary infertility. So there won't be any RPL, but the males are infertile. Okay, so for what are the common causes of male infertility? So basically, there are basically three categories. So the spermatogenesis process itself is disrupted, and the male is not able to produce healthy sperm cells. Azoospermia, that is, blocks the ability to even produce sperm cells. So there is absolutely no sperm production in this condition. And oligozoospermia is basically very low quality or very poor quality sperm production. So what are the causes, genetic causes? So some syndromes like Klinefelter syndrome, which is basically an XXY, these are basically infertile males. There could be congenital bilateral absence of vas deferens, which is called as CABVD, and this is usually attributed to mutations in the cystic fibrosis genes. There could be Y chromosome microdeletion. So these are small deletions in the AZF region of the Y chromosomes. This again lead to oligospermia, and then single gene disorders like Noonan syndrome also lead to infertility. So just quickly recapping, what are the techniques that can be used to look at these conditions? So for example, all chromosomal abnormalities like sex chromosomal abnormalities, Klinefelters or chromosomal rearrangement can be investigated by doing a simple karyotyping. For Y chromosome microdeletions, we use a PCR-based methods to look at these small deleted regions. And again, for single gene conditions like CFTR, which causes CABVD, and Noonan-like syndrome, we use next generation sequencing, either a panel or a clinical exome sequencing can be done. Right. So I will now talk about products of conception and why it is important to look at products of conception. So what are products of conception is a medical term that is used for tissue derived from the union of an egg and a sperm. So basically any embryonic or fetal material that is derived post fertilization is a product of conception. It could be in the form of a blighted ovum, which is an anembryonic pregnancy. It could be a first trimester loss product, which is between 1 to 12 weeks. It could be an early second trimester loss, which is 12 to 20 weeks. And then post this, it is really termed as IUD, which is death of the fetus in utero. And this basically happens after 20 weeks. And then finally, last but not the least, we also have to keep in mind the cases which are of stillbirth. So unexplained stillbirth is also comes under this category. And there are genetic causes attributed to stillbirth also, which can be investigated by genetic testing. So let's look at miscarriages that take place between 6 to 20 weeks. So 20 to 50% of all first trimester miscarriages occur due to chromosomal abnormalities. So it's a quite high percentage of abortions taking place due to chromosomal abnormalities. And roughly out of these 50%, 2 to 3% will be due to balanced translocation in the parents. So from these 2 points itself, it is very clear that for any miscarriage, it is important to investigate what was the cause of the miscarriage, and hence POC analysis becomes very important. Okay, so before I go into the details of POC analysis, I just wanted to highlight over here, because we'll be talking about different techniques, etc. But what I wanted to highlight with this slide is that what are the different types of genetic investigations and why they are different. So if you can appreciate this picture over here, this is the figure of an entire chromosome. Okay, so these chromosomes are only visible when the cell is in a metaphase state, which means that it is dividing. If the cell is in the resting phase or not dividing, then the chromosome DNA actually exists in the form of this solenoid structure, or it is unwound and it is just kind of floating around and not really in the form of chromosomes. Okay, and this can further be unwound into chromatin fibers. And then this is just plain single-stranded, double-stranded DNA. And last but not the least is the smallest unit of DNA, which is a single base pair, right? So you can appreciate that right from the whole chromosome, which is huge in size, to a single base pair, which is the smallest unit of a chromosome. So obviously one technique is not enough, or one technique cannot investigate the changes that takes place at the chromosome level, or at the solenoid level, or at the chromatin fiber level, and then at the single base pair level. So obviously here what I have listed is the appropriate technique to look for these different changes. So for example, any chromosomal level changes can be viewed under a microscope, and they are basically either numerical chromosomal abnormalities or structural chromosomal abnormalities, right? And these need to be looked at by a karyotype. Again, submicroscopic copy number changes, which means that there are changes at the level of the chromosome, but they are too small to be seen by a karyotype. So you need to use a molecular technique like microarray. Smaller deletions, duplications than that are basically looked at by techniques like MLPA. And then you finally have single nucleotide changes, or which are basically single base pairs. So these are investigated by sequencing technologies. Over here is the basically the units in which the chromosomes are measured. So for example, the largest chromosome is about 200 megabases, which is 10 to the 6 base pairs. So, and the smallest change in a chromosome that can be picked up by a karyotype is about 5 megabases. And then you have the range of between 5 MB to 100 MB, 100 KB. This is microarray, investigated by microarray, and then smaller than that by an MLP. And then last is when you have single base pair changes, or about 10 to 15 base pairs. These are basically investigated by a next generation sequencing, which is highlighted over here. So this is a karyotype, a microarray in between, and then MLPA looking at even smaller deletions, 1 to 100 KB, and then you have next generation sequencing. Increasingly now in next generation sequencing technology, we are also reporting copy number variations. So not really like numerical copy number variations, but at least variations which are ranging in this particular range. However, it is not a diagnostic technique and has to be confirmed by a additional method. So what are the different type of chromosomal abnormalities? So as I have said, you can have numerical, which means that either more than 46 chromosomes or less than 46 chromosomes, right? So 46 is basically 23 pairs. And so if there is an additional chromosome or one less chromosome, then that is called a numerical abnormality. You can have structural abnormalities, which comprise of deletion, duplications, and the third one is the rearrangement. So this slide talks about the different type of rearrangements that are possible. In the interest of time, I won't go into detail, but one of the most common ones that we encountered, which are responsible for RPL, are the Robertsonian translocations. So Robertsonian translocations are nothing but translocations that take place between acrocentric chromosomes. So that is 13, 14, 15, 22, and 21, basically. Okay, so now looking at POC with karyotyping. So what are the limitations? It is very important to, till about a few years ago, this was the gold standard, and this technique was being used by everybody for looking at all prenatal samples, right? It is still a pretty powerful technique and still considered a gold standard. But with products of conception samples, we run into some issues with karyotyping, which are that it has a very low diagnostic yield. So only 3% of the cases a diagnosis can be made. It's a time-consuming technique, and at least takes about 2 weeks, 2 to 3 weeks, 3 weeks literally to get back the data. It misses the small changes, so anything above below 5 MB is not picked up, and it's heavily operator dependent, which means that that an individual has to call the results basically. Okay. Another technique that is commonly used is FISH. FISH is also very sensitive and a very powerful technique, but the only issue with FISH is that it is targeted. So we have to know what probes we are using, and in case of prenatal diagnostic, it is only limited to the common trisomies that exist, right? So FISH can be used, but then you are getting only limited information. So this is the ACOG guidelines basically, which came out, and then in the ACOG guidelines now for any prenatal sample or a POC analysis, a chromosomal microarray is the test of choice and is the first line of test that is being recommended. So again, these are the reasons why a chromosomal microarray has been recommended, because of high failure rate in karyotyping and increase in diagnostic yield by using a chromosomal microarray. Okay, so what is a microarray? A microarray is nothing but a device containing probes that test for the absence or presence of specific DNA, and you can also do it on RNA molecules, right? And there are different types of microarrays. At MedGenome, we use a microarray which uses both oligonucleotide probes as well as SNP probes. Okay, so this is an important point to remember, because this actually helps in diagnosing other, factors like triploidy. Like if you have SNP probes on a microarray, you can detect triploidies or maternal cell contamination, or sometimes uniparental disomy also. Okay, so how does it work? The patient's DNA, or in this case, the products of conception DNA, is taken, and it is, labeled. So basically, a fluorescent label is attached to the DNA, and then it is passed over this kind of, it's like a glass slide or a chip, which contains about 750,000 or or 350,000 probes, which are these probes are designed across the genome. So all the chromosomes are probed, and these probes are evenly distributed across the genome. So once the DNA binds to the probes on this glass chip, the excess DNA is washed off, and then because there's a fluorescent label on these on the POC chromosome, it is then subjected to imaging. So this is the raw image that is obtained in a microarray, and each of these dots that you can see here represents some or the other portion of the genome. Okay, how do we detect the changes? So basically, it is the gain of fluorescence or loss of fluorescence. So if in the areas where there is a low fluorescence, it means that here there is a loss, which means that enough DNA hasn't bound here, and that is why the area has become dark. Or if there are extremely bright spots, then this is considered as a gain. All this is determined based on a background data. So background data is nothing but thousands of normal samples run on the microarray to create a background, and anything fluorescence above the background is a gain, and fluorescence below the background is a loss. So it's pretty simple and straightforward. This is again depicting how the data is seen. So if it's a deletion, we just see 2 tracts. If it is a duplication, we see 4 tracts. And normal, it's a 3 tract, basically visible on a microarray raw data. So this is a case study, this is a POC case, and we attempted a karyotyping on this case, but the karyotyping actually failed. So whatever remaining tissue we had, we extracted the DNA from it, and we were able to detect it on the microarray, and we found that this sample had a trisomy of chromosome 20, and that was most likely the cause of the loss. The next example is actually talking about unbalanced translocation. So remember, I had told you at the beginning of the presentation that at least 2 to 3% of all genetic causes of RPL are attributed to balanced translocation in the parents. So when there is a balanced translocation in the parents, as is shown over here, this is nothing but exchange of chromosomal material between 2 chromosomes. Okay, so here you can see a part of this chromosome purple has gone here, and simultaneously a part of the yellow has come to the purple chromosome. So what this means is that there is no net gain or loss. The genes present here will still be expressed, and the genes present in this yellow chromosome will also be expressed. So in any individual who has this situation, they will be absolutely normal. They will not have any pathogenic indications, and so it is usually missed. Okay, but however, when either of these situations is inherited by the fetus, so as you can see over here or here, it causes an unbalance. So in this situation, as you can see, there is an extra yellow material, plus there is a loss of the purple material. And over here, there is a loss of the yellow material, and there is a gain of the purple material, right? So any imbalance of resulting from a balanced translocation will be a gain and a loss accompanied together. As is seen in this case. So this is the case of a 24-year-old female with 4 consecutive pregnancy losses, and each pregnancy, every pregnancy had basically lots of congenital anomalies. They were not same, but nevertheless, there were lots of congenital anomalies in every pregnancy. So POC, finally, in the 4th pregnancy, a POC microarray was done, and this is what was found. As you can see here, can you see the small red one bar over here? So this is indicated over here. This is basically a loss, as is indicated by a red bar. And this is a gain, again on chromosome 16 over here. So this is basically a gain, right? So when we come across these kind of situations where a loss and a gain are seen simultaneously in a sample, we are more than sure that this is happening. It is an unbalanced event, and might be happening because the parents are carriers of a balanced translocation. Okay. The other thing to remember is most of the time these loss and gain events are at the edge of the chromosome. So now talking about the sample type. So POC sample, this is a whole placental tissue. So we don't need the whole placenta. We just need a small piece of tissue. You can send it in either saline or in RPMI media with 2 to 3 drops of any antibiotic added to the medium. It can be shipped in basically any container. But the most important message is that we don't need the entire tissue. We just need a small piece of the tissue. What will be the microarray detect? It will detect. So one of the common questions I get asked is that, will a microarray pick up everything that a karyotype does? So yes, the answer is yes. It picks up all numerical chromosomal abnormalities, sex chromosome abnormalities, microdeletions, subtelomeric deletions, and all other deletions and duplications, and sometimes even uniparental disomy. Okay, now, and this is a chart which actually talks about POC samples which are obtained at different gestational ages. So the first example is a blighted ovum or an embryonic pregnancy. So here in this scenario, POC testing is actually not recommended. And the reason for that is because this is actually not an embryo, it's just a blighted ovum. So you are anyway not going to get the correct genotype in this case. So any molecular testing over here is actually not advisable. One should directly proceed for a couple karyotyping and or genetic counseling to determine further tests. If a pregnancy is lost between 6 to 10 weeks, it is very important that once the fetus is expelled, or if it's a medical termination of pregnancy, it is important to identify the fetal tissue. Okay, because the problem then arises that if this fetal tissue is contaminated with maternal material, we cannot do molecular testing, or the molecular testing fails because the maternal DNA is mixed with the fetal DNA. And so molecular testing won't be possible. So if there is a situation where you are not able to distinguish between the two types of tissues, then it would be better to attempt karyotyping rather than a molecular test, or a FISH test could also be done. Okay, now 10 to 20 weeks, between 10 to 20 weeks, this works well. Again, important to isolate the fetal tissue, and always in this instant, if a fetal tissue has been isolated, we should proceed for microarray. And most important is that for all POC samples, we also need to do a maternal cell contamination test as per the CAP and ACMG guidelines. So along with the POC tissue, we recommend sending 3 ml of maternal blood. And beyond 20 weeks, these are the guidelines. So if possible, a fetal autopsy should be done. At centers where autopsy is not available, facility for doing a fetal autopsy is not available, at least take pictures of the fetus. And if there are skeletal abnormalities, then I would recommend that if X-rays can be taken, right? So that's explained here, and depending on what kind of findings are seen in the fetus, we can recommend further testing such as microarray or next generation sequencing based test. Okay, so we've already spoken about microarray. I would like to talk a little bit about next generation sequencing. So next generation sequencing will pick up small scale variants like single base pair changes as seen over here, A to D, G to C, or absence of a single base pair. Here there's a deletion of a single base pair, or sometimes there's an insertion of bases, and these changes are called as indels. Okay, so what next generation sequencing, what are the options available? We have targeted panels, we have carrier screening panel, and then when there is uncertain diagnosis, we can go for broad tests such as clinical exome sequencing or whole exome sequencing. Okay. So what are the scenarios in which next generation sequencing is recommended? So fetal anomalies repeating in cases, and the cytogenetic evaluation done is normal. So for example, a POC sample has been run on a microarray, and the microarray is normal, but obviously it's a recurrent pregnancy loss with the same anomalies recurring in fetuses. So then we can go for a next generation sequencing based test. If there is sexual ambiguity in the fetus, okay, if there are skeletal deformities, conditions like hydrocephalus, or there's a family history of genetic disorders like hemoglobinopathies, X-linked disorders, metabolic disorders, or there is, polycystic kidney. So these are some of the scenarios where a next generation sequencing has to be offered. So this is a case of thanatophoric, lethal skeletal dysplasia. So you can see that there are micromilic extremities, and then basically ventriculomegaly and small cerebellum were found. Okay, and basically this is caused by mutations in the FGFR3. So when there is such a case, then obviously there is no need to do any microarray. We straight away proceed with either FGFR3 sequencing, or we can offer a skeletal dysplasia panel to this such kind of cases. Okay. Now, there will be some cases where POC material is not available in recurrent pregnancy loss cases, right? So maybe the couple has had 4 or 5 losses and they approach an IVF specialist or a obstetrician and tell them that, we have had this history, but we have not been able to save any products of conception or test any products of conception. So the step 1 in this case is always to rule out hereditary chromosomal abnormalities. So the first step would be to perform a couple karyotyping. If the couple karyotyping is normal, so if a couple karyotyping comes back as balanced carriers, then you know that is the cause of the miscarriage. And then subsequently, you can decide to go for donor gametes, or you can decide to go for PGD analysis. In case the couple karyotyping is normal, we need to then offer detailed genetic counseling to the couple. Only after genetic counseling, we need to decide what are the further tests, like we could offer a couple carrier screening. So these are some of the couple carrier screening reports that I have over here. So their first female child was clinical indications of fever with motor neuronal regression. And actually here the index case was available. So we did a whole exome sequencing on that. And then we found these 2 variants. And when the couple carrier screening was done, they were both found to be carriers of the same variant. So here we have established that the parents are carriers. It's a recessive condition. So there is a 25% chance of inheriting this in the next pregnancy. So such a couple can be offered prenatal diagnostics, or they can be offered PGTM, which is a IVF. If they choose to go through IVF, then you can screen the embryos before implantation. Okay. Again, this is a case where there was, the child was actually born, but there was respiratory distress, bilateral foot contractures of the knees, and the child was also found to be affected with congenital heart defects. And so the child succumbed at this point. So again, no testing was done on the child for whatever reasons. So the carrier testing was done in the parents, and we could identify these 2 variants. This is a myopathy variant. So then this was followed by clinical correlation, and so on and so forth. So basically, this case is just highlighting that when you do carrier screening, you might sometimes encounter variants of unknown significance. And for those, we need to do a very thorough clinical correlation before taking any prenatal diagnostic decisions. Okay. So I have a quick slide about maternal cell contamination. So why is it important to do maternal cell contamination? What does it look like? So these are 2 examples of CVS samples. This is a very clear villi, whereas here you can see contaminated with maternal blood. So try to send us few strands which are looking like pure white. And these are various degrees of contamination in amniotic fluid. Basically any molecular test done on these samples will fail. So if you have visibly contaminated samples like any of these 3, we prefer culturing the cells before we attempt any molecular testing. Okay. So this is my final slide, and some of the take-home messages from this presentation. So POC analysis is recommended in all multiple pregnancy loss cases, and preferably after 2 consecutive losses. Depending on when the pregnancy is lost, appropriate testing needs to be recommended, as I've already explained. If testing cannot be done for any reason, this should be given on DNA storage. So this is very important. If the couple cannot afford testing at that particular time, DNA storage can be done. It is very inexpensive to do. I've already highlighted about fetal autopsy. So wherever possible, do a fetal autopsy if it's an IUD. And again, one test does not fit all. So recommending a correct molecular test is very important. And if there is an affected index case, the index case needs to be worked up before we look at the fetus. So this is a common request that comes to us, that the first child is affected. Can you see the fetus? No. The answer is no. We need to first work up the index case and then look at the fetus. And then importance of maternal cell contamination. So this was my final slide. Thank you all for your attention. And I think the questions are at the end. So thank you very much.
Thank you, Dr. Priyadarshini. I think we'll move on to the next presentation in the interest of time. Over to you, Dr. Shweta, if you could share your screen and start your presentation.
A very good evening to all of you. I'd like to thank MedGenome for giving me this opportunity and Dr. Priyadarshini, madam, for joining in. My topic for today is IUI, intrauterine insemination, when, how, and when not. So the most important question that each one of us asks is, in the age of IVF, where an IVF center is springing up in every nook and corner of the city, is IUI even relevant? The answer to this is a resounding yes, because IUI is certainly effective in selected group of patients, but it's important that we know when we do it, how we do it, and how not to do it. So firstly, let's look at the subset of patients where IUI won't work, where we have to straight away go for IVF. This includes patients with grade 3 or grade 4 advanced stage endometriosis, patients where the husband has a severe male factor, that is severe oligospermia, women with bilateral tubal pathology, couples facing genetic issue, women with poor AMH or advanced age. Of course, AMH and age, both of these parameters can't act as the final decision-making factor, but it's prudent that in a woman with AMH less than 1, we recommend her to either go for only 2 or 3 IUI cycles or go straight away for IVF. And couples in whom previously IUI has been done for 4 to 6 times and yet it has not been successful. So if we leave aside this pool of patients, the rest of them are suitable for IUI. So this includes couples with unexplained infertility, couples with grade 1 or grade 2, that is minimal or mild endometriosis, couples with mild male factor, women with ovulatory disorders, couples with sexual dysfunctions, and all the indications for donor semen. So the donor semen indications include azoospermia due to testicular failure, or azoospermia where the couple doesn't afford PESA, TESE, and other things, severely abnormal semen parameters, couples with hereditary diseases, and a severe case of Rh isoimmunization. So before taking up a woman for IUI, what are the prerequisites? So AMH has to at least be 1.5. That will indicate a good ovarian reserve. At least 1 tube has to be open. In the husband, the post-wash count should at least be 10 million. Yes, this figure is a little bit controversial. Sometimes it's said that the post-wash count or the total motile inseminating count has to be at least 5 million. But below 5 million, it's contraindicated. Also, one has to look at the hormonal profile. If there is a thyroid issue, we need to supplement it. If there's a prolactin issue, then we have to start on capgolin. These days, we also do serum B12 and calcium levels. Also, a word here on random sugar or the HbA1c level. A lot of times, women with unexplained infertility or PCOD women will have a random sugar around 160 or 170. So in these cases, it's very important to correct the sugar and then begin the treatment. So the common dilemma in clinical practice is, let's say a 25-year-old woman with the 2 years of infertility comes in, the basic hormonal profile is normal, husband's semen analysis is normal. So what do we do? Do we do a laparoscopy first or do we do an IUI first? So if there is any symptom so as to suspect a pelvic issue, let's say if she has persistent dysmenorrhea, or if the baseline day 2 or day 3 TVS shows ovarian cysts or an obvious endometriotic cyst or a small polyp, for these things it would be prudent to first do a diagnostic laparohysteroscopy and see for the pelvic atmosphere. In other cases, it would be good to do 1 or 2 cycles of IUI, see the ovarian response, see if she's responding, ovulating, if the IUI is giving desired success. If not, then probably after 2 or 3 cycles, we would do a laparoscopy and then do the next 2 or 3 cycles. So the first step in IUI is induction of ovulation. Commonly, we use 3 drugs: Clomiphene, Anastrozole, and Gonadotropins. So the most common question is, if a woman is normally ovulating, is ovulation induction mandatory? Yes, it is. Even in a woman with normal cycles, if you induce ovulation, the success rate or the chance of a live birth is higher. So what are the goals for optimum ovarian stimulation? We need to have at least 1 to 3 follicles between 18 to 20 mm. Yes, a lot of you might think 3 follicles, but yes, in certain subset of women, it's okay to have 3 follicles. Endometrial thickness has to be at least 8 mm. And the drugs have to be simple to administer, cost effective, giving best possible success, and with least side effects. So broadly speaking, women with infertility can be classified into 2 groups: ovulatory women and unovulatory women. So in ovulatory women, the goal is to make 2 to 3 good follicles. While if you look at the anovulatory subset of patients, the World Health Organization has classified them into 3 groups. The first group is Hypogonadotropic Hypogonadism. In these women, the typical hormonal profile will be AMH is normal, while FSH is on the lower side. So if you're looking at an AMH of 3 and FSH of 2 or 1.5, then it's a hypo woman. She will not ovulate on Clomiphene or Anastrozole. We will have to give her Gonadotropins. The second and most common subset of women is PCOD. Here FSH is normal and AMH is high. So if you're looking at an FSH of, let's say, 5 and an AMH of 10, then this is PCOD. And the third group of women is premature ovarian failure women. So if you're looking at an FSH of 10 or 20 and an AMH of 0.1 or 1, 0.5, then these are POF women. So technically speaking, in such low AMH and such high FSH in this atmosphere, gonadotropins alone won't be enough. It would be good to start her on an Ivf cycle before she loses out on whatever oocytes she has, and maybe 2 years down the line, 3 years down the line, she will be left with only one option of donor oocytes. So before she reaches that stage, it is prudent to go for an Ivf cycle and avoid unnecessary IUIs in this woman. So if we just do an IUI without any induction of ovulation, the success rate is around 3 to 4% per cycle. If we give Clomiphene, the success rate would be 9.5% per cycle. And if we give Gonadotropin along with Clomiphene, the success rate would be 13%. So unequivocally, Gonadotropins increase the rate of live baby birth. So here we have 2 very important commonly used agents. First is Clomiphene Citrate and second is Anastrozole. Clomiphene Citrate is typically used in the doses between 50 or 100 mg per day. If we give more than 100 mg per day, then the anti-estrogenic effects like thin endometrium are very common. Clomiphene can be started anytime between day 2 to day 5 of the cycle. But the earlier we start Clomiphene, let's say if we start on day 2 instead of starting on day 5, the chances of better multifollicular development are more. Anastrozole has been available again recently in the last 5-6 years. It's again a very good drug. The doses are between 2.5 to 7.5 mg daily. The advantages of anastrozole are, because of its unique action, what we typically see when we give Clomiphene Citrate is that follicles are formed nicely, but the endometrial thickness sometimes is not very well developed. So the endometrium lining is only 6 mm or 7 mm. Anastrozole, on the other hand, will also give us a good endometrium along with a good follicle. Also, there are some women, especially the PCOD subset, which will not ovulate on Clomiphene Citrate. So these women who are CC resistant can respond to anastrozole. There is an extended anastrozole regimen also that is being given these days, where you give anastrozole for 10 days from day 2 onwards. The dose is 5 mg per day, but I personally have no experience of this regimen. Now coming to the use of gonadotropins. The most commonly used gonadotropin in IUI is your basic HMG, human menopausal gonadotropin. It is of two types, urinary and highly purified. Typically, the HMG injection is given from the last day of clomiphene or anastrozole. So from the day 7 or let's say day 6 of the menstrual cycle. The second most commonly used gonadotropin in clinical practice is FSH. However, the use of FSH in IUI cycle can't be justified because of its high costs. So FSH is again recombinant and highly purified. It is typically given in an IVF cycle from day 2 or day 3. Again, the third gonadotropin is recombinant LH. Again, because of its high cost, its use is not justified in an IUI cycle. These days, there are increased research papers which document the use of LH in women with low AMH. They say that in the final stages of ovarian maturation, just before ovulation, the body produces LH. So in women where the ovarian reserve is on the lower side, they do not have the ability to produce that much LH. So it makes sense in substituting that LH, let's say on day 7 or day 8 of the cycle, along with your routine FSH. But again, as I said, in an IUI cycle, this use is not justified. Then we have Gnrh antagonists. Routinely in a routine IUI cycle in a routine woman, this antagonist use is also not justified. Yes, there are certain cases like PCOD women where there is hyperstimulation where we can give antagonists. I will come to that later. Then we have GnRH agonists like Lupride. They are also again typically used in an IVF cycle to down-regulate, to bring down the hormones to a complete baseline so that when we begin on day 2 of the next cycle, we start on a clean slate. And the second most common gonadotropin that we all use is HCG. This is used for ovulation. It can be either urinary, highly purified, or recombinant. Either of it can be used for IUI. So as I said, HMG is adding HMG to the ovulatory drugs increase the live birth rate ratio. So the three commonly used regimens for gonadotropins are the conventional regimen, the step-up regimen, and the step-down regimen. Conventional is the most commonly used regimen. It is also the most cost-effective and almost physiological. Here we start HMG on the last day of clomiphene or anastrozole. That is, if you start, let's say, clomiphene on day 2, we start HMG on day 7. 75 to 150 mg daily is the dose. Now coming to the second regimen, that is step-up regimen. I have not used it. This is typically used in women with PCOD. Here, a very low starting dose, let's say 37.5 mg is used, and slowly stepwise we increase the dose. On day 8, we call the woman for TVS. If we see a follicle above 10 mm, or if her serum estradiol is more than 200 picogram, we logically say that one dominant follicle is going to produce 200 picogram of estradiol. So if the serum estradiol is 200 picogram, it means that one follicle is being properly formed. Then in that case, we reduce the dose. Otherwise, we keep the same dose. And the third regimen is the step-down regimen. Here we give it in very high dose from day 2 itself, and slowly we decrease it as the TVS picture suggests. But the easiest and the most cost-effective way to use HMG would be the conventional regimen. Now coming to the second step of IUI, that is transvaginal sonography. The ability to do a quick and a near-perfect transvaginal sonography is probably one of the important abilities we need to equip ourselves with. There are two parameters that we have to see. First is the endometrial thickness, and second is the size and number of follicles. So the desired time of giving HCG, that is the trigger injection, is when the follicle is 18 to 20 mm. Recently, I've come across a lot of research articles that are stating that if clomiphene citrate is used as the drug of ovulation, then it would be it would be more prudent to give the trigger injection when the dominant follicle is around 22 to 24 mm. I myself have also found that when I'm using Clomiphene Citrate and I give HCG when the dominant follicle is around 22 to 24 mm, rather than giving it conventionally at the 18 to 20 mm size, the success rate of the cycle has increased. At the same time, we also have to look at the endometrial thickness. We have to make sure that the endometrial thickness is at least 8 mm. Coming to the third step of IUI procedure, which is the sperm preparation. There are two basic techniques for sperm preparation that are universally used: swim up and density gradient. In an IUI cycle, swim up is okay, it's good enough. Absolute contraindication for IUI is when the total motile sperm count is less than 5 million. So there are so many couples who undergo IUI when the total motile sperm count is 2 million, 1 million, 2.5 million. It will give very less success rate. Although there are a couple of papers on the internet saying that you can do it when the TMSC is 2.5 million. It is good practice to stop at IUI if the count is 5 million or less. So if the semen sample has normosospermia, the morphology is normal, motility is normal, count is normal, then a simple swim up technique is enough. If the semen sample shows oats, that is oligoasthenoteratospermia, then density gradient method is superior. Again, sometimes on the day of IUI, the semen quality is suddenly inferior. In such circumstances, it is good to obtain 3 split ejaculates. In the first ejaculate, the sperm concentration is obtained of a better motility, lower viscosity, and better quality. Also, it is important to adhere to the Kruger-Strict criteria. Morphology has to be 4%. If less than that, it would be better to take the patient for ICSI rather than waste time and money in IUI. Now, coming to the actual technique of IUI, the patient should be on a semi-full bladder. She should be given in a lithotomy position. Cervix is exposed with a bivalve speculum and rinsed with saline. Catheter is connected to a 1 cc tuberculin syringe. From the test tube, some sperm suspension is withdrawn up to 0.5 ml. And gently, using the catheter, the sperm suspension is injected into the cervix. There are 2 types of IUI catheters. First is a rigid single sheath catheter, which cannot be bent. This can be used in relatively simple cases. And the second type of catheter, which is the costlier one, it is a double sheath catheter with an external flexible sheath. This type of catheter is especially used if the uterine orientation is slightly weird. That is, if the uterus is very acutely anteverted, or if it is very much retroverted, or if the cervix is tight, or the previous cycle we had some technical difficulty in doing IUI, then it's good to use such kind of a double sheathed catheter. So how about number of inseminations? Majority of the centers do only 1 IUI, which is typically done 36 hours post HCG. Some papers have also shown that doing 2 inseminations is better. In that case, the first insemination is done 12 hours after HCG, and the second one is done 24 to 36 hours after HCG. So if today HCG is given, tomorrow will be first insemination, and day after tomorrow will be the second insemination. Now coming to post-IUI management, that is luteal phase support. Yes, luteal phase support is to be given in all women. It can be given in 2 methods, vaginal progesterone or oral dydrogesterone. Vaginal progesterone is cheaper, but it will have lower patient adherence. Oral dydrogesterone will be costlier, but it is quite palatable. Both of these will have similar serum progesterones as well as similar results. So now coming to the practical aspects, that is, where do things go wrong? What are the common hindrances that we come across in a typical IUI cycle? The first problem would be an ovulatory problem. So normally what we expect is we give her Clomiphene Citrate or we give her Anastrozole. She will ovulate. On typical day 12 or day 13 or day 14, we see a nice 18 to 20 mm follicle, a nice 8 mm endometrium. If this doesn't happen, then we give her HMG. We call her again on day 13, day 14. We are expecting a follicle and a good endometrium. But in some cases, this doesn't happen. So these are poor responders. Poor responders are the end of the spectrum patients. So these are going to be women with a very low AMH and with a very high AMH also. So if a woman typically with an AMH of 0.5 or 0.4 or 1 or even 1.5 sometimes, what happens is we give her Chromophene Citrate, a very high dose of Gonadotropins. We call her on day 12. What we see is a typically small ovary, no follicles, smaller sized uterus, and a thin endometrium. So here we are looking at a woman with reduced ovarian reserve. So either we have to try one cycle with an increased gonadotropin dose, or we have to counsel her to stop and go ahead with IVF before her time is up and she is left with the only option of a donor oocyte. The second, poor responders can also be resistant PCOD women. So in these women, they are typically obese, maybe with the underlying thyroid and a prolactin issue, a raised sugar level. We have previously given them only clomiphene, not ovulated. Then we have given them anastrozole, not ovulated. Now we have given them clomiphene and gonadotropins in the highest possible dose. We have called them on day 12. We have done a TVS, and now on TVS we see a typical string of pearls appearance, not a single dominant follicle, large bulky ovaries. So now we know that we are looking at a woman with resistant PCOD. The endometrium typically here will be thick, or let's say polypoid. So here again, instead of mindlessly increase the dose of gonadotropins and trying again and again for an IUI, it would be better to counsel her to go straight away with IVF. Who knows, in the first cycle itself, she'll be able to make 10 blastocysts, which will help her for 2 pregnancies in her later life. Now coming to the other end of the spectrum, which is hyper responders. So these are the women who will produce a lot of follicles in the standard dose of gonadotropins that we give. So who are hyper responders in a typical IUI cycle? So those women with 2 dominant follicles more than 15 mm on the day of HCG administration, or those women with more than 5 follicles above 10 mm on the day of HCG administration. So these are the women that we know are going to land up in an OHSS if we don't manage them well on the day of HCG injection. So what do? The first is we cancel the cycle. A lot of times patients don't accept it because they have built very high hopes around this. So the second best option is to give an agonist trigger. So, but we only have to keep in mind that when we give an agonist trigger, we have to solidly support them in the luteal phase because of the luteolysis that these agonists do. So we have to give them oral or vaginal progesterone without fail. And the third, rather best possible option is to convert the cycle into an IVF cycle. This also sometimes is not acceptable to patients because financially they have prepared themselves to do an IUI, and suddenly here we are increasing the costs and telling them to undergo an oocyte retrieval and then an embryo transfer later. But here we have to counsel them that they have produced a lot of follicles. These follicles will go waste otherwise in an IUI cycle. So in fact, I tell them that to make these many follicles, another woman would need thousands and thousands of rupees of injections, while you have produced these many follicles only in so many injections. So in fact, this is cost effective for her. So if we are able to properly counsel them, then these hyper responders are also willing to convert their IUI cycle into an IVF cycle. We have had so many cases where IUI was converted to IVF and now these women are pregnant or they have already delivered. Now coming to TVS related problems. The most common problem on TVS that we see is we see 2 nice follicles 20 by 22 millimeters, but the endometrium is thin, it's hardly 7 mm. So in these cases, we have to supplement the endometrium, we have to give estrogen. This problem has arisen because of the anti-estrogenic effect of whatever drugs we are giving. This especially is more commonly seen if we give clomiphene citrate and less commonly seen if we give anastrozole. The second confusing picture that we can see is that the patient has taken tablets from day 2, she has taken maybe 1 or 2 injections of HMG, and she directly comes up on day 12. So you put in a probe, you see an endometrium around 7 mm, but you see a large 2.8 by 3 mm by 3 centimeters follicle. Now you're confused because you don't know whether this is a cyst, a baseline cyst, whether it is a follicle that is going towards a luteinized and ruptured follicle, or whether this is a developing follicle which is getting mature. So in order to avoid this confusion, it is always important that baseline, when she comes to us in the first 3 days of her MC, before we start her with any kind of ovulation induction, we do a basic TVS, if not TVS, at least TAS. So we know whether she has a baseline cyst, whether the ovaries are endometriotic, whether there's a small polyp, whether there's a small fibroid. So all these things, adenomyotic uterus, these things shouldn't come as a surprise on day 10 or day 12 of the cycle. We need to know all this before we take any patient for IUI. Now coming to procedure-related problems. The most common problem that we face is tight cervix. We take a typical cannula, IUI cannula, and we put it inside the cervix. It just won't go. You face resistance at the level of os. So in these cases, it would be good to use a malleable cannula with an external outer sheath that negotiates correctly through the passage. And then later on, you put an internal sheath that slides in smoothly. And then the other most common problem is regurgitation of semen. To avoid this, the first thing we have to do is do the procedure slowly. Second thing is avoid filling the IUI cannula with more than 0.5 ml. It's actually said that the more inseminating amount you put in, the chances of regurgitation and failure of that cycle is increased. So 0.5 ml is enough. And the third thing we have to do is we have to prevent the IUI cannula from touching the fundus. So we have to just stop short of the fundus. It is not recommended that we do every IUI USG guided, but that much of clinical expertise where you just negotiate through the internal os and stop there, that much is enough. So where do we stop? Usually it is not recommended to do IUI more than 6 cycles. Now let's come to the special cases, special subsets of women. So the first subset of women is women with grade 1 and 2 endometriosis. So if these women, the age is less than 35, AMH is more than 1, then we will give her gonadotropins along with clomiphene and do at least 6 cycles of IUI are recommended. If AMH is 1, less than 1, irrespective of her age, then if she is having concomitant endometriosis, it's better to take her up for IVF before she loses out on that window. And if the age is above 35 and yet her AMH is more than 1, then it would be fair enough to give her 2 chances of IUI where we give gonadotropins along with clomiphene, see if she conceives, if not, take her for IVF. Stage 3 and stage 4 endometriosis, we straight away go for IVF. Now coming at the most common pool of patients, that is unexplained infertility. If age is less than 35, then we recommend 3 cycles of plain CC. If not, 3 cycles of CC along with gonadotropins. So total 6 cycles. If age is above 35, maybe just 2 cycles of clomiphene citrate along with gonadotropins. If she conceives, okay. If not, then we take her for IVF. As I said, rescue IVF, a very popular and a high yielding procedure. A woman, particularly a PCOD woman, is planned for IUI. She takes her clomiphene tablets, takes her gonadotropin injections and comes on day 8 or day 10. And we put in the probe and we see a lot of follicles. She has obviously over-responded. We counsel her for IVF. Instead of giving her a lupride or a agonist trigger and doing IUI, what we do is we continue the stimulation. We take her for oocyte retrieval. We take out all the eggs. We'll make embryos. We'll freeze them, and in the next cycle or maybe a month later, we will do the frozen embryo transfer. Coming at the most common pool of patients, that is PCOD women. First, we'll give only clomiphene. If she ovulates, if she conceives, well and good. If not, we'll give clomiphene along with gonadotropins. If she responds well, then maybe 4 to 6 cycles of IUI. But as we discussed earlier, in spite of giving gonadotropins and clomiphene, if she is absolutely not ovulating, then rather than mindlessly increasing the dose of gonadotropins, it would be better to take her for IVF at the earliest. Now, I looked up at the internet for various RCTs for IUI, the commonly asked questions, and what the RCTs are saying. So the first important question that people say is an unexplained infertility. Does IUI have any role, or should we just do expectant management, that is wait and watch? So all the RCTs say that yes, IUI is going to give you a more success rate, better live baby ratios than only expectant management. So IUI is unequivocally used in women with unexplained infertility. The second most common question is, what is the cutoff for male factor? There are some papers that say 3 million, some that say 10 million, but a good idea is to stick to 5 million and above. Is ovarian stimulation required in a normally ovulating woman, or should we do IUI in a natural cycle? Yes, ovarian stimulation is required. It will increase the birth rate. What is the best time to do IUI? 24 to 40 hours post trigger, or 24 hours after urinary LH rise. How many IUIs do we do per cycle? 1 or 2? Ideally, most RCTs have recommended that 1 well-timed cycle in a correctly selected case is going to give you equal success rate that as compared to 2 IUI cycles in 1 cycle. How many minutes of bed rest is recommended post IUI? 20 to 30 minutes, not more than that. She can carry on her regular activities immediately. What are the optimal number of consecutive IUIs that we have to perform per couple? Here it's said that we perform at least 3 cycles of IUI consecutively. A lot of times in clinical practice, it's not possible, but it's said that 3 consecutive IUIs will give a good success. Which semen preparation technique is the best? Ideally for IUI, both of them are known to be equally effective. So, swim up is easier, so swim up is more commonly used. What is the cost effectiveness of IUI versus IVF? So as I said, at least 3 cycles of IUI in a correctly selected case is more effective. So the take-home messages would be, selection of patients is very important. Unnecessarily dragging beyond 4 to 6 IUIs must not happen. We have all had patients who've conceived in the 9th and 10th cycle of IUI, but just because one woman conceived like that doesn't justify doing multiple IUIs in other women as well. And it's very important to know when to stop and when to refer for IVF. Thank you so much.
Thank you very much, Dr. Shweta, for that very interesting talk. I now invite the audience to type in their questions in the Q&A window of the browser. So we'll just address the questions to the speakers. I think we have a couple of them. I think we can start off with Dr. Shweta. This one is for you, I think. Opinion on CC and letrozine using both for stimulation in first cycle.
Yeah, I have come across a lot of research articles that have said that you have to use both of them together. But if we look at it physiologically, CC acts in a very different way and letrozole mechanism of action is different. So rather than combining both of these together, we could rather supplement one drug along with gonadotropins. So that would give you better success rate. I myself have no experience in combining clomiphene and letrozole in a single cycle.
Okay. How is ING HCG helpful in first trimester for recurrent pregnancy loss?
Its role is very similar to substituting progesterone. It helps. A lot of times it is said that recurrent pregnancy loss in the first trimester is because of luteal phase defect. So in women now from 2006 onwards, endometrial biopsy to prove a luteal phase defect is it's no longer recommended. So luteal phase defect is more of a clinical diagnosis, and the clinical diagnosis happens only when the woman lands up in an abortion. So when we give her injection HCG, the luteal phase is strengthened. That leads to a better corpus luteum, a better embryo, and then a better success rate.
Is HCG trigger necessary in non-IUI cycle in an ovulatory cycle?
See, so what happens is in a normally ovulating woman, when the body produces one follicle, the endogenous its LH surge is enough to to make ovulation happen. But when you are giving clomiphene or when you're giving letrozole, gonadotropins, when we are aiming at a multifollicular development, the endogenous LH surge is not enough to ovulate those many follicles. Also, when you're giving CC or even gonadotropins in some case, the luteal phase is not as strong because there's so many follicles that are being formed. The luteal phase isn't strong enough to support all of that. So when you give HCG, it acts as both the uses are there. First is it helps in ovulating all of those follicles. And second is it helps in strengthening the luteal phase. So if the woman is having an ovulatory cycle, and if we are only going to give her clomiphene, going to give her gonadotropins, do her TVS and ask her to go for timed intercourse, then yes, we will have to give HCG trigger.
So once again, thank you very much, Dr. Shweta, for taking the initiative and inviting us to organize this webinar. We really appreciate your efforts, and thank you for the opportunity. And thank you again for the audience for taking time off and registering and attending this talk. I hope this was informative. And we will be sending out a recording to the audience in a couple of days. Look out for it in your chat window. If you if you have any further questions and comments about genetic testing, you can call us at our toll-free number given below, 1-800-103-3691, or write to us at diagnostics@medgenome.com. And we offer a whole range of reproductive genetic solutions, starting from NIPT to carrier screening to implantation genetic testing, and POC cytogenetics are included. So, so we'll be having more webinars in the future. So please look out for our mail in your inbox, and you can sign up. So thank you very much, Dr. Shweta and Dr. Priyadarshini, for taking time off from your schedules, for giving us this talk, and hope you had a good time presenting to this audience. So I will end this session now, and thank you very much, and good night to the audience.
Yeah, thank you. Thank you, Joseph. Bye. Good night, madam. Good night.
Bye. Good night. Thank you, ma'am.
Thank you.
Yeah.